waiting for food, you can come inside the room too, and you can get it started. I know that you have classes, some of you have classes, so I don't want to keep you. So we're very pleased to have Dr. Roland Thorpe with us here today. Dr. Thorpe is a full disclosure, good friend of mine. I've known Dr. Thorpe for many years when he was a fellow back at Johns Hopkins. I won't tell you any embarrassing stories about him, but just know that I have many embarrassing stories that I could tell if I chose to do that.
And don't ask doing question and answer.
But he's got stories about me too, so we have the mutually assured destruction thing going here, so we'll just not do that. Roland received his undergraduate degree in math from Florida A&M University, and then went on to Purdue University where he did his PhD in epidemiology. Came over to Johns Hopkins School of Medicine where he did a fellowship in gerontology, which is when we first met. And after that fellowship, he joined the center, the Hopkins Center for Health Disparities Solutions, which I used to direct. He is still there now at the center, and has now gone up the ranks from a fellow at Johns Hopkins, and he is now, as of about 4 days ago, now
Fresh.
full professor. Well-deserved, overdue, frankly, but well-deserved honor. Roland is an extremely prolific researcher. He has a 65-page CV, and most of those 65 pages is just a list of publications. He is absolutely a publication machine. What is it, 400 publications now? Something like that. A lot. All right, a lot. And so he's going to talk about he works in several areas of research, including gerontology, men's health, and in health equity in general. He's going to talk about one of the projects today, which is Black men's health study that we are working on. And thank you, Roland, for coming, and welcome.
Thank you. Thank you. Thank you. First of all, I want to say thank you to the Dean's Office, and particularly thank you to the Center for Excellence in Maternal and Child Health and the Mayor Amelia Women's Center for the sponsorship of this seminar series. And I also want to give a special thanks to Nadia Rafla and Ms. Chantrell Shelby for dealing with me, trying to get all the logistics together, and reaching out to me with incessant emails of trying to get me to respond, and I just really appreciate their patience. So what I want to do today is I want to share with you how I started this research agenda on Black men's health. And I think I was speaking to some, I forget what faculty member I was speaking to. I said, oftentimes when people come give talks, you see them give the talks and you think they always have it together all the way. But today is going to be a different type of talk. I'm going to share with you some of the things I've learned, and then I'm going to close out with some lessons learned. But before I get started, I want to just give you my full breadth of my program of research. My overarching research question is I seek to try to understand race and SES differences in health and physical outcomes in mid to late life. And so I do that in 3 buckets. The first bucket, I've tried to look at social factors and how they impact mid to late life functional outcomes. When I say functional outcomes, I'm talking about mobility limitation, the ability of older adults to walk, the inability for them to walk a quarter of a mile or up a flight of stairs. And then I'm trying to disentangle these two concepts of race and SES and how they impact these functional and health outcomes. And then the next area that I work in, spend a lot of time in, and it's an area that Thomas and I have spent a lot of time in, trying to understand the role of place and how place impact race disparities. In Baltimore City, there's certainly outside the window certainly provides a natural experiment to try to understand how social environmental conditions impact health. And I submit to you, I've been looking out a window the last couple of days in these meetings, and I think New Orleans is certainly ideal and well suited to try to understand place-based disparities as well. And then finally, what I've been doing here recently is trying to look at African American men's health or disparities in men's health. And what I'm going to talk about today is going to focus on this box. But if anyone during question and answer want to talk to me about these other areas, I will. But due to time constraints, I was just going to make sure I cover these studies are dealing with Black men's health. So what I'll do today is I'm going to try to convince you it's important for studying black men's health, or why I think it's important, and then I'll tell you a story how I got into creating this program on men's health, and I'll talk to you about some select projects that I'm working on, and finally I'll talk about one project that Dr. Levis and myself are working on currently in the field, and then I'll talk about some lessons learned and a lot of these lessons learned are going to be directed to the students, what I've learned across my course in time, and in regard to a number of different professional development things. All right? So how many people know this book? Let me do it differently. How many people read this book? Okay, all right. So good. For me, when I do research, when I think about doing research, I have to have some type of motivation. Because there are going to be good days and there are going to be bad days. And oftentimes there are more bad days than good days, right? In this business. So I see some head nods, so I know there's some affirmation. And this is the book that keeps me motivated, and in particular, it's this quote. And it's particularly this one sentence. And this is what I believe to be the sentence that keeps me motivated and driving when it comes to black men's health. I'm invisible, understand simply because people refuse to see me. So what do I mean about that? What I mean is that this book is basically about, it depicts a young man, 1952, it depicts a young African-American man, and it depicts his troubles and tribulations in, I think, New York City. And I could submit to you, if you read the book today, and you think about where we are today in society, some of those issues are still contemporary and still highly relevant. So if you don't have, but the students and all your extra spare time on the weekend, pull it out and read it. It's a page turner. How I got into this is I was guest lecturing in one of Dr. Levis's undergraduate course. I had this chart up here for another purpose. And I was lecturing and I was wondering, the students, the undergrads in there were typing, and I mean, they're really typing, everybody's engaged in their computers. I ain't that interested as a lecturer. So I figured out what are they doing? So I put on the lavalier and I walked up in the lecture hall. And as I was walking down, I noticed some people were watching soccer, some people were ordering Uggs, some people were, literally doing these things in class. Some students were doing these things. And then when I was walking back down to get back up on the stage, I noticed this graph, and what I was struck by is that ever since life expectancy data has been collected, black men have had the lowest life expectancy of all of these race, sex groups. And as an academician, the first question I asked was, why? And then I left and I went to my office, because certainly there had to have been some people working in this area. I went to my office and I did some lit searches, and I found very little stuff on this topic. And then I talked to Thomas, and I asked him about it, and I talked to the librarian to make sure I was doing the appropriate lit searches. Found a couple more articles, and then I knew at that point it was probably, I said, well, I want to do something about this. I think I found an area that I can create a niche and grow from. And in that niche, I can also combine my aging work and looking at things from a life course perspective. So one of the things I did find and did notice, some colleagues of mine, Dr. Ed or Dr. Gilbert, have worked with Robert Johnson to create this infographic that talks about the invisible man, which is really about black men. This depicts that black men have lower life expectancy and have a horrific health profile compared to particularly white men in the United States. And one of the things that, people talk about the ACA, and with the ACA being, with all the great things that came with the ACA, I don't think we're going to see the needle move with black men's health, because a large proportion of black men lived in states that did not take the Medicaid expansion. So to think that we're going to see differences in chronic disease prevalences and outcomes among black men is, I'm not too excited about that, because the states that needed to take them did not take them. But one of the things I did know was that, we know little about the health determinants of black men. And I got into this because I thought about it and I was looking around, and one thing I did know, there are a large number of ongoing studies that talk about health trajectories of a number of other segments of the population, the nurses' health study, health professional studies, but there's no one study that focused solely on the needs of black males. Indeed, there are studies, there's the Jackson Heart Study, that's the National Survey of American Life, there's the National Study of Black Americans, but they all contain a high proportion of black males, but none of them focus solely on the unique needs of African American men. And so I thought that that would probably be something that I would be very interested in. And when I started to think about building a research agenda in this area. And I'm building that research agenda so that I can be able to create an evidence base that allows me to understand these factors that lead to poor health outcomes. Because if I understand these factors that lead to poor health outcomes, indeed, I'll be able to think about having an evidence base, being able to talk to policymakers about developing new health policies that meets the needs of African American men. Also think about what is the best quality and appropriate types of care. And finally, to think about improving the efforts in primary and secondary prevention. And so one of the things that I did after I thought about, I decided to make this a new area of inquiry for me, what I did is I said I need to develop a program or a center. So I went to Tom in 2012, and I went with him in this crazy, with this idea. When I was part of the center, and I was the research, education, and training director at the time, and I had a meeting with him, and I said, hey, I got this crazy idea. He says, what? I said, I want to create a program for research on men's health in the center. He said, okay. Where you gonna get the money from? I said, I guess we gotta raise it. And he says, yeah, if you want to do that, that's the Hopkins way. You raise the money to do it. And so I said, all I need is some space on the website, and I'll figure out how to get the other stuff done. And he said yes. And I never thought that he would say yes to this, and just taking a chance on a random idea and just telling me to go raise money. And he allowed me to create this program, and he told me, he mentored me in a way that he mentors many people. He says, if you're gonna do this, you gotta do it the right way. You gotta develop a mission, and then you gotta, develop your mission and move forward and think about how you're gonna target your funding, talk to development, and all those things. And it was a great learning experience for me. And we've had it since 2012. Our mission is very simple. We want to create knowledge and disseminate knowledge so that impact research, training, and practice and policy across race and SES. And I thought it was important for me to have this last sentence that I don't think many other centers around the country that does work on centers and programs, to have this notion from across the life course, taking a life course perspective. Because I think taking this life course perspective, oftentimes what we fail to remember is when we study people in midlife, we fail to forget that they grew up to midlife. When we study people that are 65 and older, we fail to forget you just don't turn 65 one day and fall apart. That just doesn't happen, right? But what does happen is that you are a culmination of your life experiences. And oftentimes when we fail to take that into account, particularly in research studies, when we're collecting data from these cohort studies, particularly the ones that have started at 65 years of age and older, indeed, there is learning that occurs, and lots of learning that occurred, and we learned a lot of things. I did my postdoc studying people 65 years of age and older, but when I'm trying to understand why people show up at 65 differently, but then their rates of decline on health outcomes and functional outcomes are similar after 65, it encourages to think about moving earlier in the life course where things are really occurring, and gives you an opportunity to do that. And also a life course approach allows you the opportunity to think about duration and timing of events and study them contemporarily, as opposed to many times when we have studies that people are 65 and older in them, we have to ask you to think back, and then you can suffer from some recall bias. These are some of the people some of the colleagues that I've had in the program from research on men's health. One of the big things that, as you can probably see, one of the big things is that one of the key things that I do that Thomas didn't mention is I have this insatiable desire to mentor people. And a lot of these students, a lot of them have been students of mine, particularly ones with the BSs behind their names, and a lot of them have been postdocs or doctoral students that I've worked with, and they have contributed to the knowledge of the center, and I wanted to acknowledge them. The big driving framework for the program for research is the Health Disparities Research-Related framework by NIA, the Health Disparities Research Framework. And this framework calls for, if you look at it, it looks for the linkages. It asks for you to think about linkages across different domains and how these linkages work together. Too often do we do siloed research. And if we're trying to understand how to tackle health disparities or think about minority aging, I think we need to think about the synergistic effects of how these things operate, as opposed to thinking about things that are being siloed. I talked to, I think, a group of students yesterday, and I shared with them the experience of working with somebody, and a friend of mine now that's an immunologist. I didn't know how to really spell immunology when I first met him. I didn't even know what immunology was. And then we were talking, and we found out that we were interested in the same things, but he's trying to understand how stress operates in rats, and I'm trying to understand how it operates in humans, and he's trying to tell me that rats mimic humans, and I'm like, I'm not a rat, what are you talking about? So we figure out, we get past the jargon and we start working together, and I think I know for me that my science is better because of this collaboration. And I think if we're moving forward and thinking about health equity, we got to start thinking about how these things operate synergistically to produce health outcomes. And not only synergistically to produce health outcomes, we need to also think about how they operate synergistically at different points across the life course, right? So think about this. Where a person lives, where a person grows up, may have an impact on where they end up living when they're 65, because they may have grown up in a high impoverished area in, say, Baltimore City, and now they're living in, say, Ann Arbor, Michigan now, and they're retiring from Ann Arbor, Michigan. But those experiences and exposures that they had early on in their life course does have an impact and play an impact in your research, but oftentimes we don't think about those things. And so whenever I'm writing grants, and particularly thinking about papers, I do think about how these will operate together, and they help me form my my specific aims. And in addition to my specific aims, they also help me think through how my hypotheses will be driven. And finally, what they do is they help me think about who I need on my research team. That's really important, who I need on my research team. I'm not an immunologist, and I'm not a lab scientist person. I'm a social behavioral scientist person, but I do know I understand the value of working with people who understand the basic science that can help me advance and move my science forward. So here's just some brief projects that I'm currently working on in the program. So there's a supplement where I'm looking at disparities in mobility status. That's the ability to walk a quarter mile or to climb 10 steps. And I'm using the National Health and Aging Trend Study to do that. I have a supplement to do that. I'm going to talk more in detail about the Black Men's Health Survey, so I'm going to skip that now. I have a mid-career award, a KO2 award, where I'm looking at stress, and I contend that stress undergirds the relationship to mortality and how to cope with stress, and I'm doing that in the KO award. And then I have one of the third aim of my KO award is, in fact, that I will mentor people in the area of men's health and aging. And I have a colleague of mine now who's looking at religiosity and spirituality and how that impacts the relationship between stress, health, and outcome and mortality. So these are just some select projects. I have a couple other projects that I didn't put up here, but if you're interested in those, we certainly can talk about those in the Q&A period. One of the things I take to heart that Dr. Levis mentioned is that I do believe in publishing. And not only do I believe in publishing, I believe in publishing with my students. This is just a couple of papers where I've published with Sarah Hill. And so I keep this slide up here because Sarah Hill published this paper when she was a junior. And this paper's in the leading journal of men's health, American Journal of Men's Health. She was an undergraduate at the time, and I think now she's getting ready to go. Karen Bell was a doctoral student at the time, and I think the rest of these people are, well, no, Liz was a master's student at the same time, and then the rest of us is our faculty. And I just point this out that Liz now is the lead author on this paper, Sarah's on this paper, and I just take mentorship very serious, and I think scientific publication is very, very key to people's success. Even if you're not planning on going to the academy, having a publication on your paper, on your CV or resume means something. At least to me, it demonstrates that you can carry out a project to fruition, all the way from idea, hypothesis driven, all the way to the dissemination pieces. And I just want to pause for a minute to make note that this is one form of dissemination, not the only form of dissemination. Right? I want to make sure that that's clear, but for the academy in our business, this is the staple that what we go off. But if you're trying to do practice work or policy-related work, you may want to think of a different form of putting this information out. And I'm proud to say that Karen is currently on faculty at University of Maryland College Park. I shouldn't be stumbling on her. I'm glad she's not here. Don't send her the phone. But College Park, and then Sarah is going to medical school in the fall, and Elizabeth just finished up her master's degree. She's working for a nonprofit in the Bay Area. In addition to the other things that we do in the program is we make contributions to men's literature in the form of special issues. I've served as a guest editor, co-guest editor on a number of them. And here lately, last year in 2019, in January and in May, I produced 2 books. I have some colleagues. I did an edited volume on the Men's Health Equity, the handbook. This is the first handbook that we're aware of that focuses solely on the equity issues for men in general. And then the annual review of gerontology and geriatrics is another edited volume that I led that focuses on men's health and aging. So these are just some of the things that I've done and that the program has done to make dissemination of men's health, and particularly with minority health and black men's health. Now I want to move and talk to you about the research and share with you how we ended up on the Black Men's Health Survey, the Black Men's Health Project. So, you know, when we think about black men's health, or when we think about health in general, we think about, you know, there's 2 ways to gain the attention of people. Is one of the ways is the social and moral justice way, and that's an approach that's been used a lot. And one of the things that we decided to do at the center is that we started to calculate, look at the black men's health from a financial perspective. So we wanted to look at the economic burden of men's health disparities in the United States, and we did this by looking at data from the medical expenditure panel, looking using data years from 2006 to 2009, and we essentially wanted to determine the financial impact on several outcomes. The first outcome we wanted to do is look at total medical expenditures, and medical expenditures included things such as inpatient costs, emergency room, outpatient visits, prescription drugs expenditures, but not over-the-counter expenditures. And what we found is that the total direct medical care expenditures for African American men over that 4-year period was $447 billion. $447 billion. Let that rest on you for a minute. That's probably the GDP of some of the small countries around the world. $447 billion. That's just total medical expenditure. Then the other outcomes, we want to look at what we call indirect outcomes to the economy. It's the loss of productivity, which was based on number of days and missed hours from work and illness. And then also the other indirect cost was the cost of premature death. And so here we combine the total indirect cost. That was the sum of the cost of loss of productivity and premature death. And when we look here, we say that African American men had incurred $317 billion and Hispanic men incurred $115 billion. Of that $317 billion, $303 billion was directly attributed to premature death. And of this $115 billion, $103 was directly attributed to premature death of Hispanic men. And in this paper, this was put in a special issue in the International Journal, and the editors pushed us to think about recommendations. And in addition to thinking about recommendations, they wanted us to think about what could be some next step. So this one sentence we toiled over a lot. This last sentence that we wrote, that's in the paper, it took us about 2 days to get this sentence and the wording of it properly. And so we went around, all of us had different opinions of what it should be on the paper, and this is where we landed that, you know, we can't not afford to overlook disparities. And failure to do so is both socially and morally wrong. And as you can see, it carries huge economic consequences. So basically, if you don't believe in disparities, it's okay. But if you don't do nothing, it's still costing you something, right? So why not, if we're gonna take the money and we're gonna spend the money, why not spend it on trying to help them, right? And so articulating this paper got a lot of attention and a lot of media attention. And we were just kept driving home the point that we need to do something for African American men and for Hispanic men. And so in the paper, we laid out some objectives because they asked us to lay out some recommendations as well. And so one of the recommendations was, we had two recommendations. And the first recommendation, we wanted, our long-term goal was to enroll a national sample of U.S. black men 18 years of age and older. And we wanted to be able to examine and follow the trends for general health over time. And then the short-term goals, we wanted to conduct a pilot study to establish the feasibility of engaging black men across the country. Because some of the chatter that we were receiving is, oh, you can't recruit black men. And I was like, you can't recruit black men? I've been in a couple studies. Am I black? I don't know. You can't recruit them. And then so we decided we got some pilot funding. Again, like I told you earlier, Thomas told me you can do what you want, but you got to raise the money. So we started putting this game plan together, and we started applying for the pilot money, seed money at the university and local foundations. And we were able to obtain some funds. And the first thing we wanted to do is we wanted to know one simple question. We want to have some focus groups. We want to know one simple question. Why do black men go to the doctor and others do not? And we did some focus groups around the different locations around the country. Here are the areas that we planned on. How did we get on these areas? We got on these areas because we had colleagues that are black men in these areas. That's how we got on it. There was nothing more scientific about that. Myself and Thomas were in Baltimore, Washington, D.C. area. We had a colleague, Dr. Dan Howard, at that time he was in the Raleigh-Durham area. We had Dr. Neighbors in the Ann Arbor, Detroit area. And we had Dr. Derek Griffin, who was in the Nashville, Tennessee area. We went in and we conducted focus groups. We had a questionnaire. We wanted to get some basic demographic information just to get a sense of who we were actually talking with. And then we had the topics in the focus group session. These 4 topics. We wanted to talk about what does it mean to be a real man. And we want to talk about health and how do you get help for your health, and then how do you reach black men for messages and materials. So all of this, we wanted to learn this information and gain this information because the one thing we wanted to do is we wanted to develop a questionnaire that was unique and was built by black men for black men. And that's what we were doing, and that's what we were starting out to do, and we were starting out with the basic information. And so I just want to share with you a few quotes real quick on what we've done on each one of these areas. So being a real man, we asked the question, how does a man handle illness? The respondent said, I think a real man that we perceive as a macho, they actually handle illness or sickness, that they don't handle it well because they feel I don't need to go to the physician or the healthcare system because that's a sign of weakness. So going to the doctor is a sign of weakness, right? Although it could be some type of chronic condition, they say, which is the black man, I'll just deal with it instead of seeking treatment and trying to improve the overall health, and they're more apt to say I can tough it out when that's not the right approach in my opinion. So there's a lot going on in this quote, in this comment. The person knows that they should be doing better, but they also are expressed, although I know I should be doing better, I don't do better, right? Then here under the health regime, this is the question that that was posed. Do you think black men's experiences with health are different than that of men from other groups? First, I believe, especially white men, because they tend to have more money and power, so they can go to therapy and they can pay for it. Typically have jobs that will support it. They'll directly come like, hey, I'm having whatever issue. The job says, okay, take X amount of days off and see if that's sorted out. Whereas for us, where we tend to be at the lower end of the pay scale, we may not even have health insurance at all, so we're definitely not going to go. I might get a bottle of bourbon or something and just try to sleep it off. These are comments from real men that are making these comments. So this gentleman, obviously, as you can see, is thinking about there's social economic disparities and how they approach the job, and there's disparities in the job, there's disparities in the NCS, and how they deal with these experiences of health. And then finally, we have what makes it difficult for black men to seek professional help. One person says, if healthcare was very affordable, I think it would be a lot easier for black men just to walk into a clinic and say they have a certain problem. watch this, I've been having chest pains, having chronic headaches. Otherwise, you're just like, I could take some Advil and it will go away. I've only had chest pains once or twice. It didn't bother me too much. So these are some of the stories, the real stories, the life stories that you see and hear. And then I don't think pride has much to do with it now than it may have had to do with it before. I think now it's just more about money and transportation. Not really, because there's a hospital or clinic pretty close to almost everywhere, unless you live in a rural area. So these quotes, now we start to think about, we've learned through these quotes, there's socioeconomic differences between whites and blacks. Then their approach to health is quite different. The access to issues are different. And then finally here we see one of the social determinants of health that pops out here is transportation, and how that impacts. We know transportation is known to be impact access to care. So we took these focus groups and we went through and we developed themes, and then we determined what we did also was that we created an instrument based on a literature review and based on some of the information we learned from the focus groups, and we put together a questionnaire. And then what we did was half of the men that were in the actual focus group, and then we sampled another men, and we did some quasi-cognitive type testing of the interview. We wanted to know, did they understand the questions? What was anything wrong with the wording? So we went back to them to do that, and after we did that, we then took the questionnaire and we created a web-based approach to administering the survey. And so from creating that web-based survey, what was born from that, what we call the Black Men's Health Project. And we think that is the largest and most comprehensive campaign to date around black men in U.S. history. With the 3 people that served as co-PIs on this study from the Black Men's Health Project from the beginning, myself, Dr. Levis, and Dr. Harold Neighbors, and then we had a marketing company that we work with to help us market the project. And it's interesting, we call this study, notice we call it a project and not a study. Because we asked during the focus groups, what would they prefer? We call it a study or a project. And we were in Raleigh, North Carolina, and we really started, they were really adamant about not study, because a lot of those men remember Tuskegee. And so this is one of the things, had I not done that, I would have probably gone in and been like, let's call this study and let's keep going, right? But this is just one of the things that you learn when you do these focus groups, and there's value in engaging at least the people who you would like to recruit in your study. And so what we've done is we've called it the Black Men's Health Project, and we made sure that we are careful about when we do use the word study and how we use the word study. And one of the things here is we see this is another graph of the life expectancy, and as of 2017, we see that the life expectancy of white men is 76.7 years, and then we see that the life expectancy of black men is 72.5 years. That's only 4 years, and you might say, well, Roland, that's 4 years. What is all the noise you're making around this life expectancy? This is the second slide you showed me this on. But if we consider a historical perspective, the life expectancy of white men at 72.5 was in 1989. That's a 25-year lag. That's a 25-year lag. And so what is it, what is occurring over these 25 years? What do we think is going on? Why do black men live sicker and die sooner? Well, there are some well-defined common behavioral explanations that black men typically take more health behavior risks than their white counterparts. Another piece of the puzzle is that black men delay health screenings and wait longer to seek medical care and medical health attention. I always say that men in general, but I know this to be true for black men, is black men believe in health, by and large, not all of them, by and large, believe in health repair and not health maintenance. So what I mean, the first time we enter into the healthcare system, we're probably on a gurney in the ER, right? And we should not do that. We should take more preventive cares. And then black men are more reluctant to disclose physical and mental health problems, particularly mental health problems, because the stigma associated with mental health problems in the historical context of how mental health patients have been dealt with in this country. So those are some common behavioral explanations, and I agree with those common behavioral explanations, but I do think that there are some things that are missing to one piece of the puzzle that I think that has been omitted from the literature and that should be added in the literature, and it's these key determinants here. We need to think about, these are some key determinants around Black men's health that oftentimes we don't see a lot of them in the studies that have a large proportion of Black men. Particularly this notion of masculinity, now sexual orientation, religiosity, and spirituality. We know by and large for Black men, earlier in the life course, Black men tend to go to church, particularly in the South, because you're going with grandmama. And you're gonna go to church with grandma, you're gonna be at church all day with grandmama, you get home at 3 o'clock, then you're gonna go eat over to somebody else's house, and then by 9 o'clock you get home, you missed all the football, you love grandmama to death, but you missed all the football and you gotta watch it the next day. You can tell that's an experience I've had. But then Black men tend to come back into the church later on in life course. And so those are some, I have a couple colleagues that are now looking at religiosity and using a life course approach to this. And then segregation, Thomas and I have done a lot of work around this notion of segregation and where people live and how that impacts their social and environmental conditions. And we know that segregation, I've always been amazed at this institutional racism, how something that can be outlawed for over 50 years and still have lingering effects on health and well-being today. I'm just amazed at that in major metropolitan cities like New Orleans, Baltimore, Milwaukee, LA. And another area that I think that we don't do a lot in that is a determinant of health is actually incarceration. There is a body of work with incarceration that is growing, and then the other areas is racism and stress. So what we decided to do after doing a lit search, we decided to include on our survey as many of these as possible on our baseline survey. And we have medical mistrust, and we have masculinity and things like this. This is the Black Men's Health Project, the website to it. And we notice here we call it a survey. Now, again, we're not using the word study. We have the Black Men's Health Project and then the survey. You can go to the website. The website has, in addition to taking the survey, it's a destination site where there's other information around Black men's health that you can look at. And if you go there in your spare time, you may be able to find some, at least 3 YouTube videos, one from this handsome young man named Roland who's talking, and then you may see a handsome young man named Thomas Levis who talks about racism, and then we finally with this other handsome older guy named Harold Neighbors. A wiser guy named Harold. I just said it because he wasn't here. But wiser guy named Harold Neighbors. And it's just a wealth of knowledge, and we're so excited about getting this launched. And let me tell you a little bit about the goal of the study. This is a planned longitudinal study, but we're collecting baseline data. And our goal is to have a sample size of 5,000 men, 18 years of age and older. And in this R01, we're actually, this R01 project within a center project. And our goal is to start to think about how these determinants of health impact the health trajectory of Black men. But this is baseline, so we're not looking at health trajectory, we're looking at health status, health behavior, and health-seeking behaviors across different age groups. And then when we go longitudinally, we can impact and invoke the life course. But we're using some life course principles to help us guide our hypothesis and our thinking. Now, 3 specific aims. We're going to look at the impact of psychosocial and behavioral factors, how they impact depressive symptoms, how they impact cardiovascular risk, and then how they're correlated with physical functioning among Black men. One of the most unique things there are 2 unique, innovative things that we believe about our project is, one, that we're doing it web-based. People said that you can't recruit Black men across the web, and we said, well, let's test it. This is science, so let's give it a try. Let's test it. And we have been able to recruit them successfully to date using social media, largely Facebook and Twitter, to get in contact with them. And then the other thing that's really innovative, I think, about the project is our sampling design. This sampling design that Dr. Levis first found an article on it, and he sent it to me, and then we discussed this article. It's the notion of using quota sampling. Quota sampling is a non-probability sampling technique. The sampling techniques that many of the, all of the federal surveys use are these multi-stage complex sampling designs, and they have these complex ways in which they are going to sample people that are really inefficient when it comes to recruiting understudied populations, of which African American men are one. And so we decided we're going to do this non-sampling probability approach to see if this approach is just as good as the multi-stage sampling approach. And with the multi-stage sampling approach, even when you do that the older ages, there are small numbers of men, so to be able to study rare diseases and things becomes very difficult to do. And so quota sampling it's been widely used in market research. They use it all the time to target certain groups of people on predetermined characteristics. And so, it involves selecting subjects into particular subgroups and using predetermined criteria known as quotas. In our study, our quotas are the education level is the region of the country, Northeast, the region of the country is the education level and the age level. And what we've decided to do is we use the census data to determine the required proportions of each subject needed in each one of those buckets. And as a result of doing that, this should create you a national represented sample based on those quotas. And so what we're doing now is we are actually recruiting to fill up these different buckets, and then once we do that, we're going to be able to test whether through our sampling method, whether the prevalence of chronic diseases are different than the prevalence of chronic disease for men, black men who were actually recruited through, National Health Interview Survey. So that's one of the major innovations of it. Here's some proposed measures that we have. Our outcome measures are larger cardiovascular risk and depressive symptoms and mobility limitations. And the cardiovascular risk is, we're looking here at cardiovascular risk. We have self-reported measures of hypertension is our major cardiovascular risk. And all of our questions either come from, they're validated scales, either coming from the National Health Interview Survey, other scales that have been validated. And then the independent measures, we have some unique independent measures that are unique to black men. Adverse childhood experiences, microaggressions. We elected to do microaggressions and not discrimination. There are a number of papers that we already know about discrimination and black men, but microaggressions are more nuanced. And we thought that we could, at baseline, this would be more innovative. Then we have a masculinity scale. And then we wanted to look at smoking, drinking, and physical activity. And then our area level characteristics, we're going to link these measures to census level data, and we're either going to link them to zip code level data or census tract level data. And here's our proposed covariates: age, education, income, sexual orientation, marital status, health insurance. These are the proposed covariates that we are taking in the study as well now. And the study has 5 components to it. We timed it. It takes on average, about 19 minutes to complete if everyone was to answer all of the questions all the way through, but there are skip patterns in some of the questions. So it's about 19 minutes to complete. And on the website, the men can stop and come back, because they go in and they register with their email address, so they can stop and come back and take it. We give them up to 2 weeks to complete it. We've learned that for the men, if they're on in one sitting, we have high chances of them completing it in one sitting. If we have to go and catch them and track them down, and the probability of them completing it becomes very, very slim. And at the end, people get a $15 gift card code. This is the one of the things I told you I wanted to tell you. What we've done in the study is that with the study, I want to tell you about one of the struggles I've had. I'm being open with you all. So, when you look at that web page, do you see any reason why anyone else beside a black man would register? Well, we thought that the case was, when you look at it, only or the black men were registered. But what we found out when we did some quality checks there, we found out that women were logging in. And some people look at me like, well, how do we know? Because when you log in, everybody had to log in with an email address, right? And so, I'm just making up a name because I'm not going to tell you people's names. Hillary Clinton at hotmail.com. Hillary Clinton is a female name, right? So I can't suspect that it's a black male. So one of the things that we have decided to do, we've had a number of women email addresses that have logged into the site, and we've identified this problem and notified IRB, and we have had some course of actions that we're taking now to avoid against that. That's one of the things in primary data collection. One of the things you learn quickly when you're in the field, things are not going to go as planned, as always planned. So, but we have now had to think about how do we verify race and sex through, we're using different APIs now, what we're currently using. So if when a person logs in and they put their email address in, then it goes through a database that returns, as a part of the screening process, it returns race and sex, and if it matches in black and male, then it goes through. If not, it screens out. We didn't have that before. But now, on the flip side, one thing that was raised when I was talking to IRB, that could be the case, but I don't think it's the case for the number of people we have, that some of the people could have been filling this out for their father or their uncle, and so there's no way of us really verifying that. We went back in to IRB to ask permission to be able to contact them to see if that is the case. And so we're working diligently with these email addresses that we have to be able to identify them, because what we want to do is, our conservative approach was just to kick them out the data set and then not use them in the data. But the IRB thought that it would be wiser for us to at least investigate this a little bit and determine if we could use the data and if we couldn't. The sad downside about it is we still had to pay them for completing the study. I'm not going to tell you how much it costs, because I know to the penny in my head how much it costs. It stings. I don't even know you know how much it costs, but it stings really bad. It's probably the most expensive thing that I've spent money on that I don't think I get a good return on. So we have to spend a little over $8,000 paying the people in that. So these are one of the things that you live and learn through research but to date, we also, in spite of all that, our goal is 5,000 men. We're currently at 2,985 men. And we're very excited about that. And we're getting ready to actually go. We had to take the study down while this was going on. And we also, while it was down, we did some maintenance in the background, and we're getting ready to go back live. So if you see a link coming from us, it's real. And if you're female, just don't respond to it. I'm just trying to get to 5,000. And if you know someone, a black man that you think will participate, we'd be greatly appreciative of you forwarding the email information along. Finally, real quick, I want to go through some key lessons learned. And this really is for the students. These are some things that I learned on my journey. Mentorship is necessary and important. I have some quotes. One of these is I'm a big quote guy. If your mentors only tell you that you're awesome, it's time to find other mentors. I want to publicly say, and I haven't done this to Thomas, but I thank you for mentoring me and just putting up with me. I know I've been hard-headed, but thank you for having some patience and practicing patience. But I can promise you, he did not tell me things were awesome. He did not tell me I was awesome. So I just wanted to publicly say that. You're the only mentor I haven't publicly said that to. So now I'm complete.
But you are awesome.
But yeah, but not on other things. And then the other thing I wanted to say to you, I can't stress enough the goal of publishing. If you're working with your faculty members and they invite you to publish with them, it's a skill. And it's an occupational hazard, but it's a skill that I think I believe it's an occupational hazard. But it's a skill that I think you will learn and you'll use it the rest of your life. One of the things I like to leave people with when it's talking about writing, strive for excellence. Perfection doesn't exist. 90% and out the door is better than 100% and on your desk. A is a A is a A, all right? Then resilience. You got to have the resilience. You know, you got to be able to get up when things don't go right. You got to be resilient. You got to know how to get up and keep going. Well, I learned resilience in a big way when this thing happened with the finding out with our quality check. And then finally, you got to find your happiness. And happiness, I believe, sits at the corner of happiness, success. Success is not the key to happiness, but happiness is the key to success. If you love what you're doing, you'll be successful. I absolutely love what I'm doing. I'll take any questions that you have. I think I got it. Yes.
I have a quick question, and thank you. So, I guess it's a little bit ironic, though. In your sampling and recruitment, and because it is a web-based project, do you find any issues with accessibility? Because the men that you want have to have access to internet or a platform that will allow them to take the survey. So, like, if you're sampling at somewhere like Xavier or Morehouse, where, of course, there's laptops and things everywhere, I feel like won't that kind of skew your data a little bit versus maybe other places where it's inaccessible to your web-based survey?
We haven't had, that's a good question. Thank you for the question. We haven't had the that issue with accessibility. So it's interesting. People think that black folk, particularly black men, don't have accessibility to the internet. And when I did my focus group, I mean, older men, younger men, all of them had access to smartphones. And you can take the survey from the phone, or you can take it from a web-based platform. That was one of the things that we made sure that you could do. And there's a Pew Trust report that came out that showed that about upwards of 85% of people had access to internet. So we haven't ran into that problem yet, and I hope we don't run into it. Yes.
I just wanted to add that from a marketing standpoint, the market is pretty saturated with African Americans and the use of social media and having access to the internet now. It used to be that African Americans, especially those in rural areas,
right,
were really, there was like a dearth of access, but that is no longer the case. And as a matter of fact, with smartphone and wireless access, they're the #1 target market because they overuse in that area.
Yes.
Did you have any trans men that participated or attempted to participate in the study?
Not that I'm aware of yet, but we do have I don't know the answer to that because we do have questions around sexual orientation and that in this study, but I haven't looked at that data. But and that's a very good question that you asked because initially when we first had put the survey together, we didn't have that in there. And I forget where I was giving a talk at, someone brought it up, and it just did not occur to me. Then I went back and talked to Thomas and Woody, and we added some questions on the survey and sent it back to IRB for approval. So we do have questions that we'll be able to look at that. Yes?
I'm curious about the representability of this method of sampling. How could we say it's representable and use education as one of the covariates when we are sampling on education?
Okay. So then if we sample on it, we shouldn't be controlling it. Yes. So if I add it up as a covariate, that's inappropriate.
Okay.
Right? Yes.
Great talk, thank you so much. So I was just wondering, since you're looking at a life course and you are looking at younger men and you are looking at sexual orientation, is there any consideration of including STDs and sexual behavior because it is such a huge health disparity?
So we have not included that, but our colleague Maria Trent has been in my ear about it, and I told her when we want to get this baseline sample, and so let me pause for a minute and tell you the purpose. We want to get this baseline sample, and then when we go back in the field, we talked about adding additional questions, and then we're thinking about having a call to determine what other additional questions that we want to add. But first, when you're trying to recruit black men, you can't overwhelm them and say we're gonna have a thing with 1,000 questions. That ain't gonna go down. They're not gonna answer that. But I believe once we get the cohort and we develop a much better relationship with them, we can tend to add in more questions. But I do think that those questions of STDs would be very important. Our colleague did inform us of that very
Maria,
quickly.
yeah, did.
Yeah. You had a question, and then this young lady right here.
I just had a question. If you were planning on, or if you have looked at the quality of care that Black men receive once they make contact with the health system?
No, we don't have quality of care in it. We do have a medical mistrust scale in the survey now, but we don't have anything else on quality indicators in the baseline survey. No.
Do you have it available in Spanish for Afro-Latino?
No, we don't, because the inclusion criteria you self-report as African American, U.S. born, 18 and over.
I have two questions. The first one is, have you written, contributed to, or know of any studies or literature that discuss differences in racial makeup of families and how that affects health? So, like Black men who are dark-skinned, Black men who are light-skinned, Black men with one white parent, Black men with two Black parents, those sort of things. And then the second question is, do you have any exclusion criteria other than having to be an 18-year-old Black man? So, for instance, like, are incarcerated folk allowed to participate? And if yes, do you run into any ethical dilemmas with, like, possibility of coercion or, like, persuasion to participate?
Right, so to answer your first question, I have not written on anything like that. I do not know of any study that specifically focused on Black men per se like that, but I do know there's a body of literature that looks at that color, color and colorism. I do know that there's a body of literature on it, but I don't know that literature. So I don't know the answer to that question about the literature, but I haven't done that. And then their second question is, we don't recruit incarcerated men, but you could have been priorly incarcerated. Right. Yep.
Can I add something? We do have the skin color measure.
Did it make it in?
We have.
I don't remember, right.
So we do have that, so we will be able to look at that. Beast. And then incarcerated men, anyone who can access the internet can access the survey. So if they're in prison and they have access to the
Right.
internet, they can take the survey. But the fact that they're a prisoner is not
a requirement, right.
Include or exclude from the study.
Right.
Dr. Thorpe, thank you for your presentation. I'm a student in the Maternal Child Health program, and I'm really interested in what your thoughts are about the name Maternal Child Health, because it seems like a lot of this research is directly related to maternal child health, but I feel like it's often siphoned, like issues with men's health or, just in general with men. So I'm wondering, if you think that that's really not an issue, or how we could better integrate. Because we have all various research centers or classes that are focused on maternal child health, and how do we link that up with men's health?
So, thank you for the question. I think maternal and child health is very important. I don't think it should go away. And I don't think this should be a zero-sum game, right? I think, men are a part of the family structure, right? But I think what we need to do, in fact, the maternal child health at HRSA they have this huge initiative about fathers' engagement in maternal child health. And they have this National Healthy Start program that is occurring, right? And so I think that including fathers in maternal child health, and there's a program that's going on where one approach to get fathers preventive work is that when the men go to the doctor with the mother for her prenatal care, they have they have opportunities to go down the hall and get their preventive care, and think about preventive care from the standpoint of having yourself being able to be in good health so that you can be around for your child. So I don't see it as a zero-sum game. I think that I don't think it's an either or. I think it's a both, and I think that being able to integrate fathers into the maternal child health, where I think there's a big push now that is actually occurring now. Whereas about 5-10 years ago that wasn't the case, but I do know now that the Maternal Child Bureau through HRSA, you to go to their website, there's huge information around fatherhood, and then there's this whole push outside of the maternal child health about fatherhood and the importance of fatherhood as it relates to the family and the child health and the mother's health. Yes?
I'm sorry, I want to just interrupt a moment to pause, because I know at least some of you, your professor is waiting for you to come to class. So, that's not everybody, but I know some of you maybe need to. Sorry, go ahead.
Thank you.
I mean, we have time here, but I just wanted to let those people know. Please go ahead.
Continue on the question.
Okay, sorry.
So how could we represent two samples when we are not? It's hard.
Yeah, but it's represented because your link, you use census data. You find them, the weights of the quotas is based on the census. So American community, so that percentage